Thanks for coming this morning. We've got a great talk coming up. We're really excited to have Dr. Adam Salisbury come from Mid-America Heart in Kansas City. Dr. Salisbury was trained in medical school at University of Missouri and then did his medicine residency at Mayo and has subsequently spent all of his training time and is now on faculty at Mid-America Heart. He's going to give us a talk today about patients who are surgically ineligible for coronary revascularization and the challenges they pose, which I think is really sort of within our scope of practice and a big portion of who we treat. So we're really looking forward to hearing from him. Thank you.
Well, thanks for the opportunity to present this morning. It's really been great. I've been out here this week doing some cases with Bill Lombardi, and it's been fantastic to work with everyone on the team and to see how things are done out here. These are my disclosures. And I'm actually going to start with a case. This is a woman that we enrolled as one of the first patients in the Optimum registry, which I'll talk about in a moment. But she's a 65-year-old woman with a history of hypothyroidism and dyslipidemia who'd been previously well and actually presented in September of last year complaining of dyspnea, cough, and pedal edema. That was interpreted as a reflection of bronchitis, and she was given treatment with antibiotics and bronchodilators. She did not improve and, in fact, considerably worsened over subsequent months and ultimately returned to be reevaluated at the same urgent care in November. At this point in time, she was so short of breath that she couldn't walk from room to room without dyspnea. She couldn't shower without being short of breath, and ultimately was referred to see a cardiologist when it was noted that she was more edematous. She was actually admitted from that cardiologist's clinic at the outside hospital and found to have an ejection fraction of 25% with a dilated left ventricle and was ultimately diuresed to 25 pounds on their inpatient service and was referred for a coronary angiogram which showed a CTO of the mid-LAD, the mid-right coronary, and a functional CTO of a large OM1. She was noted to be too high risk for either bypass or PCI locally and was referred to our hospital. On arrival to our hospital, we obtained these images, found that she had an EF of 10%. Our surgeons did evaluate her in the setting of chronic kidney disease, poor LV function, and poor targets. They advised PCI. These are her films. As you can see, she has a CTO of the mid-LAD. The OM1 is filling late. It's a functional occlusion. And you can see collateral filling of the right coronary. And just to further image the OM, and then to visualize the mid-right coronary CTO, which collateralizes the distal LAD. So I'd like you to just keep her case in mind as we go through the talk, and really some of the implications of management for this woman. Of course, we're all thinking about symptoms, function, quality of life, her mortality, how much she is likely to be back in the hospital. But in her case, revascularization really could make the difference on requirement for advanced heart failure therapies, a defibrillator certainly, if in the setting of conduction disease, CRT, and whether she's a candidate for advanced therapies. And so I think a lot of the discussion of a surgically ineligible patient with multivessel disease is really driven by what we all see on the wards, which is an aging, more complex population. You're all familiar with these figures that show that our population is aging rapidly, and along with that population, the patients are accumulating a large amount of comorbidities. This is actually a study, it's not from the cardiovascular literature, but it's from cancer literature, looking at the prevalence of moderate to severe comorbidities. And what they found was that if you looked at the 80-year-old patients, over 40% of them had moderate to severe comorbidities that influenced their care. And we've seen this in impressions in the general media. So I think the typical bypass patient has really shifted over the years from a guy who's really fairly well and presents with a non-STEMI and has relatively straightforward lesions that, he has nice targets for bypass surgery, has nice targets for PCI, and can be treated fairly effectively and easily with bypass surgery, to a considerably sicker patient who's now 88 years old. He's had 2 sternotomies, got a bioprosthetic AVR, and he's had oxygen-dependent COPD, and his anatomy is considerably more complex, which presents challenges for us in the lab. He's got disease distal to his lima anastomosis. He has CTOs of the right and the circ, and both grafts are down, so basically he has the last patent conduit of that LAD downstream of the lima. So if I were to show a surgeon or any of us in the cath lab these films, I don't think anyone would hesitate to treat a patient who has relatively short, straightforward lesions with excellent targets. However, I think a lot of the patients that we're seeing these days and are really driving these surgical turndowns have anatomy more like this gentleman. He's got distal left main disease into the circ. He's got disease of an OM1. His distal circ's occluded, and there's a flush osteal occlusion of the LAD with a small non-dominant right, and he's considerably more difficult to revascularize percutaneously. So the question is really, who is the high-risk patient? And this is a really heterogeneous group in the sense that it's not all driven by anatomy, but certainly anatomy can be a player, whether that's poor targets, whether that's a prior sternotomy or a hostile course of a previous graft, whether they have a porcelain aorta. Certainly comorbidity is one of the major drivers here, chronic kidney disease, chronic lung disease, but it can be a host of things, whether it's immunosuppression or cachexia. And then frailty is something that we haven't thought as much about in the interventional community as our surgical colleagues have, but they'll often go into, do they really think that this patient can recover from a bypass operation? And frailty is becoming something that we probably should be considering more, but it's really a combination of all of these factors that lead to a high-risk situation for bypass surgery. But when you look at practice out in the community, the practice varies dramatically, and the question is, we really don't know what the right way is to manage these patients, because these patients are systematically excluded from trials. None of them meet the inclusion or exclusion criteria. We don't have any prospective data on how they do after more complex interventions, what their quality of life benefit is, and what their clinical event rates are. And we know from what studies we do have that the risk prediction tools that we'll use in the general population, like the STS or the NCDR cath PCI mortality risk score, really don't work well in these patients, that they undercall their risk. And we don't know about the completeness of revascularization necessary to achieve good outcomes. Do we need to revascularize every branch or every CTO in order to achieve a good outcome? And we don't have tools that can really help us balance risk and benefit to select the best patients for treatment. So what I certainly don't want to make this about is a battle between PCI and CABG in a standard risk patient. I think we all know that CABG has really won that fight, and it's the preferred revascularization strategy in patients with diabetes, with increasingly complex disease, and for the standard risk 3-vessel disease patient. But what insights can we gain from the existing literature that's looked at PCI versus CABG, and how might it apply to these populations? These are data from Stitches, the 10-year follow-up data, and essentially are data that show that revascularization does improve outcomes in patients with multivessel coronary disease. As you know, these are patients with an EF of 35% or less, most of whom had multivessel disease. And as you'll see through 10 years of follow-up, revascularization with bypass surgery versus medical therapy was associated with a reduction in death, with the number needed to treat of roughly 14, and the composite of death and rehospitalization with a number needed to treat of about 10. And in this study, the patients who had more complex anatomy or multivessel disease, in this case 3-vessel disease, did seem to have a greater benefit. And what about health status and benefit after revascularization? These are data from Freedom. As you know, Freedom looked at revascularization with PCI or CABG in diabetics. Diabetes certainly conferred a greater benefit from bypass surgery, but in this study, the health status benefits were the same. These are Seattle Angina Questionnaire scores, and this was conducted through our institution by Dave Cohen, essentially comparing the groups with CABG and PCI. As you'll see, the vast majority of patients at baseline had severe symptoms, either daily, weekly, or monthly angina. But by 1 month follow-up, both groups experienced dramatic improvement in their symptoms, and the majority no longer had angina symptoms, and this persisted through 60 months of follow-up. But what I will have you note is there wasn't a particular difference between the patients treated with PCI or CABG, and there was no significant difference in our analysis. How about clinical events? These are data from the Syntax study through 5 years. And as you'll see, this was a study where Taxus stents were compared to bypass surgery in patients with left main or multivessel disease. CABA was superior with regard to the myocardial infarction endpoint, repeat revascularization, and MACE, certainly partly reflecting the PCI technique of the time. But I think one of the insights that can be gained in this that may relate to the completeness of revascularization discussion in surgical turndowns is what is this gap and where does it really derive from? These are those same data actually stratified by Syntax score. So this is the low-risk Syntax group. And what you'll see is that the outcomes of PCI and CABA are relatively similar. And as we go into the intermediate risk group, and the high-risk group, what you'll notice, PCI performs progressively worse, and bypass surgery does about the same, which shows us they're doing a far more effective job of revascularizing these complex patients, where PCI really tails off. And although there's some suggestion that PCI may be getting better, these are data from Syntax 2, which looked at comparable patients with multivessel disease who were treated with contemporary PCI, that's using FFR, IVUS, and Synergy stents. We noted lower event rates, particularly with MI and any revascularization. We certainly think that most of what we saw in Syntax was related to this disease that wasn't treated. These are actually data from the Acuity study, looking at how much disease was actually treated by the interventionalists in this study. And they did that by calculating residual Syntax scores. They calculated a patient's baseline Syntax score, then their Syntax score after revascularization, and the difference was the residual Syntax score. Obviously, you're looking for 0 if you completely revascularize the patient, and as you have progressively more residual disease, your residual Syntax score goes up. But what you'll notice is in patients with complete revascularization versus very incomplete revascularization, the delta Syntax score, or the amount of disease that was actually treated during the PCI, was about the same. And you'll note that in patients with residual Syntax scores that were low, these were very straightforward lesions. Most of them were not calcified, they weren't chronic total occlusions, and they didn't involve bifurcations. But as you move into patients who have high residual Syntax scores, you see why they weren't treated. These were more difficult lesions. They were chronic occlusions. They were small vessels with diffuse disease. They involved bifurcations and trifurcations. So there was certainly a reason why these lesions weren't tackled. But it does seem that there's an association between leaving disease behind and events in follow-up. Patients who have a residual Syntax score of 0 did best in follow-up. Patients who had a high residual Syntax score did progressively worse, and that's with regard to the MACE endpoint or any of the components of MACE, whether that's death, myocardial infarction, or repeat revascularization. And I think that's actually borne out when you look at the literature as a whole, whether you're looking at PCI or CABA. This is a large study that looked at both groups, and complete revascularization was associated with better outcomes, whether a patient was treated with bypass surgery or treated with PCI, with about a 30% relative risk reduction among patients who received complete revascularization as compared to patients who did not. Contemporary data also support this. These are pooled data that S.J. Park and his colleagues have reported from the pooled data of 3 trials of PCI versus CABA in complex disease. That's BEST, pre-combat, and Syntax. But they found that about 57% of the PCI-treated patients were completely revascularized, and about 67% of the bypass-treated patients were completely revascularized. And complete revascularization with PCI was associated with comparable event rates to CABA, but incomplete revascularization after PCI, that's your top line here, the dotted yellow line, was associated with higher event rates. So that's a long-winded background to basically set up this discussion of surgical ineligibility in multivessel coronary disease. So I wanted to first go over some of the relationships between surgical ineligibility and outcomes. I think we've certainly got some interesting data there. Describe the determinants of surgical ineligibility, review some of the prior literature comparing revascularization strategies in patients who are at high risk for surgery, and discuss some of the barriers to PCI, and then briefly describe a study that we're conducting right now to try to gain some more insight into how to treat these patients. One of the first studies that really looked at this group was conducted by Waldo and Ye, looking at a consecutive series of 1,013 patients at their center who had surgical anatomy according to the most recent AUC criteria. And of these 1,013 patients, they found that 22% had been deemed surgically ineligible prior to the procedure, and their PCI outcomes were certainly worse in comparison to the patients who were eligible for bypass surgery. In fact, an adjusted odds ratio with a 6-fold greater increased risk of in-hospital mortality. And these patients had certainly a very different risk profile. They often had poor targets for bypass surgery, but they were often old, had significant kidney disease, severe lung disease, and poor left ventricles. And as you might imagine, that drove poor short and long-term mortality. And you can see the long-term mortality depicted on these KM curves. And that's also been shown in the left main population. This is a study by McNulty and colleagues looking at a consecutive series undergoing left main PCI at their institution. About 50% of these patients were ineligible for surgery. And what they found was that these patients were also commonly affected by risk factors that weren't captured by existing risk models. And just to show how poorly the existing risk models actually predicted the patient's risk, they adjusted for the STS or the Euroscore and the NCDR PCI risk model, and after adjusting for these risk scores, there was an over 5-fold hazard associated with surgical ineligibility, which really suggests that it's a different collection of risk factors that drive risk in these individuals. And certainly when you look at traditional risk factors, these are busy tables, but these are tables from both of those papers, the Waldo paper and the McNulty paper. And while you can see that these patients who are ineligible have a dramatic increase in the risk as defined by cerebrovascular disease, chronic lung disease, congestive heart failure, there's a variety of other factors that prove that these sick patients are really considerably sicker. These are two tables from the same papers looking at some of the criteria that drove their surgical ineligibility. And while we talked about things like poor conduits, we see that advanced age, severe lung disease, renal insufficiency, but things like cachexia, frailty, malignancy, which we all know are poor prognostic markers, were major factors that are probably driving risk in these people. So what prior literature do we have that compares revascularization strategies in patients who are high risk for surgery? And the answer is we really don't have much. And the one trial that we do have is certainly not contemporary. This is the VA Awesome trial. It was actually conducted, patients that were cared for in the 90s and published in 2000, 2001. Looking at 454 patients who had surgical anatomy, refractory ischemia, and one or more risk factors for adverse outcomes with bypass surgery. These were patients that both the surgeon and the interventionalists agreed were treatable with the techniques of the era, and they were randomized in a 1-to-1 fashion to PCI and CABA. This certainly reflected the PCI technique of the time, so actually only 54% of patients even got a stent. A lot of these patients were treated with PTCA alone, and only 70% got a Lima graft. There was certainly limited background therapy. But in this study, they looked at risk factors such as advanced age, prior bypass surgery and previous sternotomy, recent MI, EF less than 35, and shock requiring a balloon pump. And at least a third of patients in each group had at least 2 of these features. But the outcomes in the Awesome trial, short and long term, were similar between PCI and bypass surgery, as were the health status outcomes as assessed using the short form 36 and collected at 6-month follow-up for all patients. So why aren't we treating all of these patients in the lab, and why aren't we revascularizing all of them completely? Certainly, I think these are the highest risk patients, so risk aversion merits some discussion. There's very little consensus as to how complete the revascularization should be, and I think as you go around the country, you see that most of it is very incomplete, and there are certainly technical barriers to revascularizing the most impactful lesions. So I don't think any risk aversion discussion is complete without mentioning these best hospitals list. They're all on our minds, and they're based in part on the death rates that we see at hospitals. So certainly taking on high-risk cases could influence these rankings. We're all aware that now hospitals, these are data from New York, are reporting the risk standardized mortality rates. And you can see not only Columbia Presbyterian as an example, their mortality rate, but their operators' individual risk standardized mortality rates. So that could certainly influence an operator's decision to take on a more complex case. And what are some of the data that have been published? There are a variety of studies. I'm just going to focus on one. This looks at the national inpatient sample and 84,000 patients with AMI, about 69% of whom were treated in states with public reporting. Patients who are treated in public reporting states were less likely to receive PCI and more likely to die in hospital. And when you look at which patients weren't being treated with PCI in public reporting states, it was disproportionately patients who were older than 65 and presented with shock, and that was associated with increased all-cause mortality. When you actually stratify that mortality, the patients who did not receive PCI were about 30% more likely to die, and those who did receive PCI were about 30% less likely to die in public reporting states, which really underscores that there's some cherry picking going on in these states. As we talked about before, these are those same data from acuity that I presented earlier. It can be difficult to achieve complete revascularization, largely driven by CTOs and complex lesions, which at our centers, we're fortunate to have dedicated operators to treat, but many centers do not have. And I think one of these graphs that I'll draw your attention to is even in patients with low complexity syntax scores, less than 22 on the left side of this graph, only 44% had a residual syntax score of 0, meaning they achieved anatomically complete revascularization. But when you look at the complex patients with a syntax score of over 32, actually almost 80% had a residual syntax score in the highest tertile, or greater than 8. So many of these patients are a long way from complete revascularization. And again, that's driven by anatomical considerations in many situations rather than clinical considerations. A big driver of practice variation is chronic total occlusions. We see data published from Expert CTO, Progress CTO, and Open CTO, all of which indicate excellent success rates in the hands of excellent operators. But we know from the NCDR that that's not reflective of general practice. We know from prior studies that 20% of patients who have coronary disease have a CTO, but they comprise only 3.8% of all PCIs in the NCDR. And in fact, as you can see on the graph at the lower left hand, at least in 2015, and I don't think that's much different today, the vast majority of centers very rarely attempt CTOs. And in fact, in this study, looking at the NCDR data, 17% of centers never attempted CTOs. The success rate was only 59% in the NCDR. And even when looking at operators in the graph along the right-hand side, who frequently attempt CTOs, that was defined as 30 a year. The success rate varied quite dramatically from about 20% into the 90s. So there remains dramatic practice variation that derives completeness of revascularization for these complex individuals. So we certainly know that all these patients need guideline-directed medical therapy, but one of our major goals is to understand how much PCI they need, whether they need PCI at all, and we need at least some early observational data to try to guide some of our practice. And that's really what the Optimum study is about. This is a prospective registry conducted at a planned 20 centers, and your institution actually just got up and running with enrollment and have already put in 4 patients. So we really appreciate your contributions and your participation. But we did have Dr. Lombardi on our steering committee, who's been instrumental in helping to guide the study. And these are the hospitals that are currently enrolling or very close to being complete with the initiation process and enrolling patients. As you can see, this is a selection of some of the leading heart hospitals across the United States. And our goal is really to characterize this population and try to describe the impacts of surgical ineligibility not only on clinical event rates, but patients' health status. And the goal was to enroll 800 patients total, with 600 of whom had been selected by the treating physicians for PCI, and 200 of whom were selected for initial strategy of guideline-directed medical therapy. And then to assess the burden of disease based on the diagnostic angiograms for all patients, that's core labbed through CRF, and then among patients who received PCI, to actually go through the index and staged procedures to see how much of this disease we were treating and understand some of the associations between completeness of revascularization and their health status outcomes as well as their clinical outcomes. And we're collecting health status using the Seattle Angina Questionnaire and the Kansas City Cardiomyopathy Questionnaire at 1, 6, and 12 months after their first PCI, 1-year events to collect MACE rates, and 5-year mortality data, with goals of feeding this back to patients to describe the anticipated risks and benefits, to describe some of the relationships between management strategy and outcomes, and to get a better sense for event rates that hopefully will inform future randomized trials. Thus far, we've enrolled about 100 patients with some considerable difficulty enrolling the medical therapy arm because most of these patients are receiving revascularization to some degree. And so I wanted to come back to our first patient that I presented who was enrolled in the study, and we proceeded with revascularization with a goal of complete revascularization. So she had a relatively short occlusion of the LAD, which I crossed with antegrade wire escalation, pre-dilated her diagonal, and ultimately stented the LAD with good result, and then moved on to the obtuse marginal, which was a functional occlusion. There was a channel that we wired antegrade, and it turns out that this was a good-sized vessel that was just underfilled on the previous angiogram. And ultimately, in the setting of some chronic kidney disease, we staged her right coronary and brought her back for PCI about 4 weeks later. We initially tried to wire the lesion antegrade and were unsuccessful, so we proceeded to a dissection and reentry strategy. And I think on the next slide you'll see the Stingray balloon is up, and we're puncturing back into the true lumen with the Stingray wire. Ultimately proceed with PCI and get a good result on this vessel as well. And while this is obviously an anecdotal situation that we're going to pick because of good pictures and a good outcome, she's done very well in follow-up. So with medical therapy along with revascularization, her initial echocardiogram after this second procedure showed that her EF had come up to 34%. And since she was borderline for a device, we repeated the study another 2 months later, and ultimately found that her EF was 45% as calculated on the contrasted echo. She did not require a defibrillator and has not been back into the hospital and is feeling well currently. And we certainly hope that that's a generalizable experience. But in conclusion, I think I've got more questions than answers about surgical ineligibility at this point, and we really appreciate your efforts to enroll patients into our study so that we can begin to better characterize and study this population. But we know that surgical ineligibility is increasingly common. We see these patients coming across the lab list on a weekly basis. We know that there's greater risk, but we think there's greater benefit. So I wouldn't take those data that indicate they're high risk as data not to treat them. While there are few outcomes data, there are new insights that are emerging. And I think certainly in centers like the University of Washington, where you have specialized operators who have all of the tools to treat these patients, they can be effectively treated with PCI and completely revascularized. And we really hope to identify some of the best practices and expected outcomes going forward. So at this point, I'll stop, and I'm happy to discuss any comments that you may have, and just wanted to thank you again for the opportunity to chat this morning and to present. Thank you.
Questions? I'll kick it off.
Sure.
So you showed Ed McNulty's data and Bobier's data about surgically ineligible patients having hazard ratios 6-fold higher than predicted risk. We know that this population from clinical care here is muddy, not always great. Talk a little bit about concepts of futility. You know, we, as an outcomes researcher, struggle with that because there's lots of issues with overfitting. But how do you, is there an upper boundary to this population? How do we find it, and how should we be thinking about that?
I think there certainly is an upper boundary, and it's something that, you know, in the interventional community, we've often said, send us everybody, we'll treat them all. But I think we're all frustrated when we take a patient who's very frail with a variety of comorbidities, and we give them worsening chronic kidney disease, and they never come back, basically, from acute kidney injury. But I think what we've gained thus far in the patients we've enrolled into the study is a better understanding of frailty. And our surgeons would say this up front. We learned this from them in the TAVR space. That when they walk into a room and see someone who can't get out of the chair into the exam table without the two-person lift, they say this person's not going to do well regardless of what you do. One of the things that we're really looking at in Optimum is frailty. So we've got a full index of their functional status with a 5-minute walk, with grip strength, but with some cognitive indices as well. And we think that's going to be really important in identifying individuals who just may not recover. Anecdotally, one of the first patients my research nurse wanted to enroll generated a call because she couldn't get, the patient wasn't strong enough to pick up the pen to sign the consent form. And this is probably not the right patient to put in the study, and they're probably not going to do well regardless, and it turns out that patient died of hypercarbic respiratory failure, completely unrelated to their coronary disease, about 3 days later. So I think there are certainly patients that we're trying to learn how to identify. This study will allow us to generate some models and identify some of the independent correlates of poor outcomes, whether they're comorbidities or whether they're frailty. I suspect it'll be frailty.
Right. That was a great talk. Thank you very much. I have a question about the data you referred to with regard to public reporting. Because I don't think it's just around the acute cases and the cardiogenic shock. There's a limited number of places. Yours probably have to go for 100 miles or more to find another center who takes on the acuity of your cases. We feel the same up here. And I've heard this issue about the reluctance of docs and hospitals to take on these high risk, but I haven't seen the second part of it, which is, well, this is a problem, how are we going to fix it? Or because the risk scores don't seem to be able to capture the complexity of these patients. And I just wonder if you had some thoughts that if this is really needed, how do we encourage it?
Yeah, I'm going to have to defer to smarter individuals on the policy front than me, but I know that we've struggled with that at our hospital, is how do we offer shock care in Kansas City, where if you present to most hospitals in Kansas City in cardiogenic shock, you're going to get dramatically different care than if you present to St. Luke's Hospital. But it's even more of an issue than that on a practice level, because across our practice of 14 interventionalists, you're going to get dramatically different care from 2 or 3 of us who are very aggressive with support to others who do not feel that many of these patients need to be taken on. So I wish I had some insight into how we actually move from the observation that there probably is a problem to how to fix it, but I certainly don't at this point. I know we're struggling with it on a practice level, and I think we'll continue to struggle with it as a community.
Mark, so we've seen 2 types of patients that you put into this category. One is the patient that we've been referred for secondary MR, mitral insufficiency. And then we get a CAT and they have horrible 3-vessel disease, viable myocardium, they get revascularized often, and then we still see the significance of the MR that ultimately is driving rehospitalizations and requires a therapy.
Sure.
And we don't see the improvement in LV. We see some improvement, but not significant enough to change the secondary MR. And then we see the other patient, which you presented, classic ischemic cardiomyopathy, gets better. How are you going to basically separate them in the study and understand those 2 very unique patient populations?
Sure, and I think ultimately it's going to require a randomized study to really have the right insights there. You know, we've done a fairly extensive job to try to collect all the baseline echocardiographic parameters and all the valve disease parameters, but at this point I don't think we know how we can play that very important game and point out who's going to recover their EF and who's not. I think the answer lies somewhere in between our surgeon's approach, which is typically to say if the EF is in the 20s it will not recover, and our approach, which is to try to treat everyone. And I think the truth is in the middle, and I think we're going to have to start with some fairly crude risk models to try to generate initial insights, but it will ultimately require more sophisticated trials to gain that insight, because we've had that same experience. And we also struggle in the valve arena, how much of this disease really needs to be treated before a TAVR around the time of a MitraClip. And I think clearly we probably don't need to be treating every distal LAD CTO in those patients, and we've been more selective, but it's going to take more data, I'm afraid. Yes?
Just to follow up on that, maybe how much is enough point, I think that this is a challenging question to ask because every patient and every lesion is different. But is there planned analysis in Optimum to try to get to the question of, for that patient, an example who you brought back for the RCA, you need to bring her back for the RCA? Because I know a lot of institutions would not have. And in the observational design that you have, are you going to be able to go back and try to figure out which degree of revascularization may be associated?
Sure, and we'll be able to look at some of the predictors of benefit, but I think in any observational design, and particularly in this design, it's going to be biased somewhat upfront by who we chose to bring back and who we selected for each management strategy. I think it does, it sounds like a cop-out, go back to individualization of care. This was a young functional woman with what we thought was an ischemic cardiomyopathy, and we certainly wanted to revascularize flow to every myocyte we could. Having said that, if this was an 87-year-old patient who was frail and largely wheelchair-bound, I think we would have been considerably less aggressive to try to achieve complete revascularization. And I think we'll be able to gain some initial insights from multivariable modeling in Optimum, but I think those will be foundational rather than something that's ready to guide care.
Great. Well, Adam, thank you so much for. Oh, I'm sorry.
At the risk of offending our surgeons, I come from Milwaukee, so that's my escape. I've noticed that surgeons are less aggressive as angioplasty techniques improve. I was in this game long enough to remember the early days of angioplasty when surgery was our bailout for all our disasters, and the surgeons were really good at taking out really sick patients because there was no option. There was no other option. And I think there's a tendency to sort of, for the surgeons to say, yeah, this one's too sick for me. Because it's sort of like, well, we've got option 2, which is an easy escape valve.
And I think that's something we see at our hospital all the time. And in fact, they are, the paradigm has shifted to where they're that last option, and now it's back to us, is that if the patient is high risk at all, or even in some cases we've been talking about if the coronary angiogram was shot on low magnification and they say, that's kind of a ratty vessel, then the patient's coming right back to us almost without a discussion with the surgeon.
The concern is that the surgery is really good. Your case that you presented, if you weren't worried about the ventricle, that would be, I think a surgeon would take that on. And I remember the days when we would take that on. I'm not a surgeon, basically. But I worry that the surgeons are giving up the imperative to take on difficult cases. Because it's easy to, say out after you, Alphonse.
Yeah, that's true. Absolutely, great point. Yes?
I'd like to reiterate that when you had a patient with pre-vessel disease, he had the 35 not unanotropes, and we had to do PCI because they were deemed not operable.
Absolutely.
Well, I have a question. Well, somewhat in defense of the surgeons, they have gone through the trouble of developing a score that defines risk for them pretty well. None of these define risk really well at the high, within the highest levels of risk, but that's really where I think we need to go. I think it's probably unrealistic to think that we can continue to do this sort of artisanal gestalty, artisanal gestalty approach to determining who we're going to take on. And I think it's probably unrealistic to think that the system can continue to support taking on people who really are very high risk and end up either dying or having prolonged hospital stays. So I applaud you guys for doing this work to look at a group of people who are at very high risk, and hopefully that can help to refine risk score among that group so we can make some hard decisions about what scores are.
Absolutely. Yeah, that's one of our major goals. And in fact, we've embedded all of the variables in the common surgical and PCI risk scores so that we can see how good they are and then see how we can augment them in a risk score that's really tailored to this population. And moreover, I think one of the interesting things we observed is the surgeons would identify particular patients that they thought were dramatically higher risk than the risk score would suggest. And so we're actually collecting the surgeon's kind of gestalt assessment as well and trying to see how that performs relative to some of the established risk scores. But clearly one of the goals is to understand better how we select people who will do well and how we select patients who won't, and tailor their treatment accordingly.
Yeah, just to amplify a little bit more on that, back in the conversation about risk aversion that was discussed a moment ago, some of this has to do with public reporting. You showed some of that information. And the surgeons, older literature is showing that when public reporting occurs, they start being more selective in their case selection. I think it's very, very incumbent, like what Kevin said, that we get something out of this that allows us to risk stratify, because what's going to happen is the public reporting is going to occur with this patient population that we're taking care of as interventional cardiologists. If we don't have some way to risk stratify these patients, and my hat's off for doing this in a very meaningful way, we're going to wind up doing some very complicated patients, but not being able to show that the outcomes were reasonable unless we have those kinds of risk models. So I think that's going to be really, really critical.
Great point. Absolutely.
I think that speaks to why there's sort of an attempt at a disease-based registry as opposed to a therapy-based registry in Optimum, and there is a desire for medically treated patients.
Absolutely.
Any other questions? All right. Well, Adam, thanks so much
Absolutely.
for coming. We really appreciate having you. Thanks everyone for being here.